Good morning, everyone. Welcome to Grand Rounds. I'm Dr. Ben Miller, the Chief of Pediatric Hospital Medicine here. And on behalf of our division, it is my honor to introduce Dr. Ndidi Unaka, who's going to be our Grand Rounds speaker this morning. Dr. Unaka is the inaugural Chief Health Equity Officer for Stanford Medicine Children's Health and a clinical professor in the Department of Pediatrics at Stanford University School of Medicine. She received her undergraduate degree from the University of Oregon in 2003, where she also played varsity basketball for the Ducks, and graduated from the University of Michigan Medical School in 2007. She completed pediatric residency and chief residency at Cincinnati Children's Hospital. Dr. Unaka joined faculty in the Division of Hospital Medicine at Cincinnati Children's in 2011. In addition to her clinical role as a pediatric hospitalist, Dr. Unaka served as the Associate Program Director of the Pediatric Residency Program from 2011 to January 2022. Prior to a transition to SMCH in July 2024, Dr. Unaka worked on institution-level community health initiatives at Cincinnati Children's. She served as the Medical Director of Quality Improvement and Data Analytics for Cincinnati Children's Medicaid-focused accountable care organization called HealthVine. In this role, she developed and led initiatives designed to improve the quality and efficiency of healthcare delivery to HealthVine's patient population and help lead the change management associated with the movement towards a population healthcare model that improves quality, narrows equity gaps, streamlines care, and reduces costs. Dr. Unaka also partnered with several colleagues to lead system-wide quality improvement initiatives, including work accelerated via learning networks, including co-leading Cincinnati Children's Health Equity Network, which supports the equity-oriented improvement work of clinical teams across the institution. Additionally, Dr. Unaka was a faculty lead within the Fisher Child Health Equity Center and specifically focused on working with operations leaders to ensure equity was embedded within all strategic plans, goals, and metrics across all sites of care. From a scholarly perspective, Dr. Unaka has over 60 peer-reviewed publications and has mentored undergraduate and medical students, residents, fellows, and junior faculty on several scholarly projects. Please join me in welcoming Dr. Unaka.
Thank you all so much for coming, Ben. Thank you for that lovely introduction. It's an honor to be here and to see so many familiar faces and friends and colleagues. So the title of my talk is From Insights to Impact, a Strategic Roadmap for Excellent and Equitable Health Outcomes. And as Ben noted, I just transitioned to Stanford in July. So all of what I am talking about highlights work that I did with colleagues at Cincinnati Children's. So the objectives of my talk are really to articulate the need for an unrelenting pursuit of pediatric population health and health equity. I hope that you all can gain critical insights from PHHE research, and I hope to illustrate how generated evidence informs and enhances quality improvement initiatives. Finally, I hope that you all walk out of here today appreciating the value of learning networks to share best practices, lessons learned, and innovative approaches to identify and narrow equity gaps. But before I dive in, I really want to start with framing why this conversation is really important, and I will do this by highlighting several patient experiences. So the first experience is with a patient that I have come to know over the past several years. He's an adolescent Black male who was diagnosed with type 1 diabetes and subsequently was the victim of a gunshot wound that necessitated amputation of his lower extremity. Over the course of 8 years, he has had multiple encounters with the healthcare system that were likely preventable, including 13 admissions specifically related to DKA, 25 admissions to the pediatric ICU, and 147 emergency department visits. This patient and his family has had multiple health-related social needs that likely impact his health and well-being. And his diabetes-related course really is demonstrated in the literature as it relates to health inequities we see in type 1 diabetes outcomes among our racialized children and adolescents. The next story is from a colleague of mine who shared this experience. She encountered a mother who presented to the hospital in labor around 2 a.m. Her baby was showing signs of distress, and as a result, the team quickly readied her for an emergency C-section. They used a Spanish interpreter, but the mom did not consent. Risk management and the legal department were called and approved the procedure, and the baby was safely delivered. Around that time, an in-person Spanish interpreter arrived, and after she met with the parents in the recovery room, they let the team know that the parents spoke Mam, which is a Mayan language, and did not understand Spanish. And this highlights the ways in which we miss the mark to provide accommodations for our families who speak a primary language other than English. And finally, this is an encounter I had as a hospital medicine attending, where I took care of a 15-month-old Black girl who was admitted to our service on one evening with a presumptive diagnosis of acute gastroenteritis. She was persistently febrile, and while she had loose stools early on in her course, she had no diarrhea for 2 days prior to admission. I remember leaving that evening being so worried about this patient. We obtained an ultrasound to rule out intussusception and consulted surgery to examine her belly. Surgery was not concerned about her abdominal exam and were adamant that this patient did not have appendicitis. The next morning, we ordered a stat abdominal CT, and she was noted to have a perforated appendicitis. And we know from the literature, as it relates to the racial and ethnic disparities, as it relates to delayed diagnosis of appendicitis among children, and how this disproportionately impacts our Black children and adolescents. And so here are the facts. Health inequities are ubiquitous among our pediatric populations. Marginalized communities of color and poor children are disproportionately impacted. And racism and discrimination in all its forms are undeniable root causes. And so I think we're all pretty familiar with the concept of social determinants of health, which is defined as the conditions in the environments where people are born, live, learn, work, play, and worship that affect a wide range of health functioning and quality of life outcomes and risks. When we think about social determinants of health, we typically talk about them in 5 domains: education, access, and quality, healthcare and quality, neighborhood and built environment, social and community context, and economic stability. And we know all 5 of these domains are very much connected to one another. In fact, we know that where you live matters. And when we think about neighborhood characteristics, we can't deny the fact that they are influenced by the legacy of redlining, and place impacts access to a number of different things, including quality education, quality healthcare, green space, public transportation options, well-stocked grocery stores, and other amenities. So this is a graphic showing the differences in life expectancy among census tracts in the state of Pennsylvania, with the darker blue areas having longer life expectancy and the darker red areas having lower life expectancy. This is a zoom in to Allegheny County, which is where Pittsburgh sits, and you can see the variation just within this county alone. In this area, individuals who live here have a life expectancy of 84 years, while in this area, the life expectancy is 66 years. And so it's our duty to be preoccupied to understand what are the contributing factors to this death gap. Furthermore, we know from work from the American Hospital Association that did a survey of over 44 hospitals across our country, that these hospitals, less than half of them have pediatric units, with almost a 20% decrease over a 10-year span. And this was a recent study published in JAMA, a cross-sectional analysis of over 23 million inpatient pediatric hospitalizations between 2009 and 2019 via the Kids Inpatient Database. And they saw that birth hospitalizations decreased by 10.6%, and non-birth hospitalizations decreased by nearly 29%. And the largest decrease of these pediatric hospitalizations occurred at non-teaching urban hospitals and rural hospitals, most of which had less than 25 non-birth pediatric hospitalizations in 2019. So again, access to health definitely depends on where you live. So let's go through a few definitions. When we talk about health equity, we really can't have that conversation without talking about population health. which is the health outcomes of a group of individuals, including the distribution of those outcomes within a group. And I love the definition from the Robert Wood Johnson Foundation as it relates to health equity. They describe it as a state in which everyone has a fair and just opportunity to be as healthy as possible. And in order to achieve this, we have to remove specific obstacles connected to the social determinants of health, such as poverty and discrimination and their consequences, including powerlessness and the lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. So now I'm going to transition and talk about a framework that we have called Population Health and Health Equity Roadmap. And I'm going to walk through each of these steps over the next few slides. And so we published this conceptual paper in JAMA Peds last year, and it's really meant to highlight a roadmap that progresses from scientific building blocks to excellent and equitable health outcomes at scale. And each of these steps are strengthened and informed by the insights from patients, families, community partners, and frontline staff. And so the first step in this roadmap is thinking about basic PHHE science, which is really focused on defining the context by which our patients and families live and using that context to develop innovations. And this section is also focused on how we can elevate critical questions, which should inform the interventions that we design. So this is one example of a study that falls into this bucket of the roadmap. We sought to estimate two things: the total inequities in population level hospitalization rates, and determine how much is mediated by place-based exposures and community characteristics. So we conducted a population-wide neighborhood-level study of youth less than 18 years of age who were hospitalized between 2016 and 2022. And we defined a causal directive acyclic graph a priori to estimate mediating pathways by which marginalized population composition causes census tract level hospitalization rates. And so this is our DAG diagram. And just to talk a little bit about what a DAG is, it is merely a graphical representation that visually depicts causal relationships between variables, where the arrows indicate the direction of the causal effect, and the structure is really designed to illustrate how one variable influences another without any feedback loops. And so you can see here from this DAG that we wanted to highlight the ways in which complex historical processes, otherwise known as institutional and structural racism, influences socioeconomic status and influences residential neighborhoods, which in turn influence hospitalization rates. So we analyzed over 50,000 hospitalizations experienced by over 28,000 patients, and we calculated the census tract level hospitalization rates per 1,000 children, which ranged from 10.9 to 143 across all included tracts. And we found some really interesting things. So what you're looking at here is the classification of census tracts into three categories: high, medium, or low census tract level hospitalization rates, and the census tract material deprivation index. If you look at the scatter plot on the right, you can see it illustrates the correlation between these two entities. And on the left, you see the map that really just highlights the spatial distribution of these census tract categories. And essentially what we found is that for every 10% increase in the marginalized patient population, the census tract level hospitalization increased by 6.2%. In other words, there was a positive correlation between a higher material deprivation index and hospitalization rates within that census tract. We also looked at the direct and indirect hospitalization rate inequities before and after adjusting for variables that we identified in the DAG. And what we found was that after we adjusted for place-based exposures and community characteristics, no inequity remained. So again, the importance of place on these really important outcomes. These results differed when we considered subsets of reasons for admission to the hospital, including asthma, type 1 diabetes, sickle cell anemia, and psychiatric disorders. So the second step in the roadmap is really focused on efficacy. And in this step, we want to really generate ideas, change concepts and hypotheses that can subsequently be tested on a small scale or in a controlled manner. And when we think about the study type that is really useful here, qualitative studies really rise to the top because we're able to explore the perspectives and experiences of individuals with lived experience and use what we find to identify and tailor strategies that better address their needs and their challenges. And so we are all very focused on the ways in which we can identify health-related social needs and intervene for our patients and families. But I think we have to recognize that medical and social care approaches are often pursued in isolation from one another and in unbalanced ways, which may perpetuate inequities in health outcomes. And so we embarked on a qualitative study that is under review currently, where we sought to generate insights from and with patients, families, and community members to design a better and more integrated care system. And what we did is we recruited 4 peer researchers. So these were individuals who were not part of the medical system. They were embedded in the community. And we said, go out and reach out to people within your community such that we can understand what their experiences are like. We did virtual interviews in English and Spanish, and most of the participants identified as minority race or ethnicity and lived within structurally disadvantaged Cincinnati neighborhoods. The interviews followed a co-designed question guide, which assessed beliefs and attitudes of how healthcare, human services, patients, families, and communities intersect when it comes to medical and social care. We identified several study themes and opportunity areas that I'll walk through, and I'll share some representative quotes as well. So the first theme is that medical and social services are difficult to navigate. Participants spent hours navigating call systems, using transportation, and sitting in waiting rooms to get healthcare and social services. And there was a tension between the time and energy necessary to navigate medical and social services and the potential benefits when these resources were actually accessed. One participant said, when you choose the option for Spanish, they leave you waiting until they find an interpreter. Sometimes I go with my niece who helps me make my appointments for me, but in English because they help you quicker. Another participant said, do not send me to a community partner where the wait list is 2 years long, and you knew that before you gave me the information. I need real resources. Theme 2, medical and social care are often reactive or non-existent when they could be proactive. Participants repeatedly highlighted how current medical and social care systems rely on patients or clients to self-advocate and have existing knowledge of how systems operate. One participant noted, I really appreciated when someone says, I haven't seen you in a couple months. What happened? Is there anything that you need? Is there anything preventing you from being able to come in and get the care you need before it gets to the point where you truly, truly need care? And another said, I have been running into lots of resources that I didn't even know existed. I know there are other people that probably didn't know this exists. The third theme was medical and social care could be more closely integrated. Participants shared that even when families know that certain medical and social services exist, access often feels unattainable or like it's being withheld. And information about services and information are often poorly communicated and or out of date. One participant noted, if I go to the hospital and I'm there, my child has an appointment, but I also need help with food, clothing. If I mention this, they can have someone come in and talk to us about it then. Another said, I would be super excited to see social services organizations at the hospital, even just there to share information or trying to share their services as they provide to people. Theme 4, medical and social service institutions are often untrustworthy. Families of color know from their lived experiences and the experiences of friends and community members that medical and social institutions often are not safe spaces. And these poignant quotes from participants were, if you had a negative experience at this hospital, what's to say that it's not going to be your experience at all other hospitals? So it never really crosses your mind to go somewhere else for care because it's already not being handled at this one place. This leads to people neglecting their health, which can sometimes be generational. And another said, people don't know about the help because they aren't asking for it. They hit on the intake questionnaire, yes, I got food to last until next month, when they probably really don't, because they probably think they're going to take their kids or something when they're really just trying to help. Theme 5, diversified teams can improve care delivery. Participants noted a lack of congruence in social identities between families and those working within the healthcare and social systems, which can lead to a lack of trust or strains between the provider, patient, and client relationship. One participant said, bringing in this extra person, in this case, a community health worker, who brings an element of diversity and who has knowledge about these things that the family might be struggling with, it gives them a sense of hope. Like, oh, okay, somebody sees me, somebody cares. And finally, theme 6, optimal care requires empathy, clear communication, and partnership. Participants were acutely aware of the power that medical providers held and recommended that doctors build trust by practicing empathy, listening to concerns, explaining findings and recommendations in detail, and meeting patient needs. One participant shared, I appreciated the way the doctor took the time to really empathize with me and understand where I was in my life, how this could be affecting me, and how this news could make me feel. She took the time to really put herself in my shoes. And finally, a good experience means that I'm getting treated like a human and not a number or a statistic. I'm treated like a human, like I matter, like my experiences matters. My voice matters, and I'm not just a needy person with my hand out. The third stage of the roadmap really focuses on effectiveness, and it's really aimed to develop and optimize or assess innovation. This step may involve using several different study designs, in particularly quality improvement science, implementation science, or quasi-experimental design. And these strategies are particularly important when doing other methods of research like clinical trials or randomization may not be feasible or ethical. So this is work that colleagues at Cincinnati Children's did to really understand the impact of a medical legal partnership on hospitalization. They conducted a retrospective cohort study to examine the effect of referring children to the medical legal partnership over a 5-year span. They compared over 2,000 children who were referred to a pediatric primary care-based medical legal partnership with 100 randomly selected control cohorts from about 34,000 children who were also seen in the same primary care clinic, but were not referred to legal aid. And what they found was pretty striking. Essentially, they found that the median predicted hospitalization rate for children 1 year after referral to the medical legal partnership was 37.9% lower if children received the legal intervention compared if they did not. This is some work we did focused on reducing caregiver hunger for children who were hospitalized on our hospital medicine service. So we did a quality improvement initiative that took place on one of our larger inpatient pediatric units. And our primary outcome of interest was caregiver-reported hunger. And essentially, we approached caregivers at the time of discharge, and we asked them if they experienced hunger at any point during their child's hospitalization. We did several plan, do, study, act cycles and addressed several key drivers, including awareness of how to obtain food, safe environments for families to seek help, and access to affordable food. When we approached families during the discharge of their child, and they actually affirmed that they were hungry over the course of the hospitalization. We wanted to understand the reasons for that hunger. And so you can see the various categories that caregivers shared with us. What rose to the top was just the expensive food that was available within our cafeteria. And second was a desire not to leave their child's bedside. And so this is our statistical process control chart. On the x-axis is time, on the y-axis is the number or percentage of caregivers who were reportedly hungry over their child's hospitalization. And we did several tests of change, but the one I want to draw your attention to is this very limited and temporary test of change we did, where we were able to secure some funds from our social services colleagues, and we gave 2 meal card vouchers per caregiver per day over the course of their child's hospitalization. And we actually focused on our Medicaid patient population because they had a much higher rate of food insecurity compared to their privately insured counterparts. Then COVID hit and we had to pause data collection for several months, but it actually gave us time to advocate with hospital leadership to make this a permanent way in which we would address caregiver hunger in the hospital. So we were able to secure permanent funding that allowed us to give 2 meal vouchers per caregiver over the course of their child's hospitalization, and we saw a notable decrease in the reported rate of caregiver hunger. And finally, the last step in the roadmap is focused on impact and how we scale and spread innovations for maximal impact in learning. And this is where the power of the learning networks really rises. It allows us to bring all of the people to the table, including patients, families, and community partners, to scale and spread interventions that work. So when we think about learning health systems, this is really a way of, again, bringing key partners together and leveraging internal data and experiences and combining that with external evidence to inform the interventions we want to test within the network. And when we think about equity-oriented learning health systems, there are some key characteristics that are important to put in place. You want to make sure that you have shared purpose, that we define the population of interest, that we are clear about what is our denominator and numerator, that we pursue rational segmentation, essentially disaggregating the data to identify opportunities to intervene, that we devise theory, that we identify our scalable unit and scale plan, and that we formalize testing and learning. And so I'm going to talk about 2 learning health systems that we led at Cincinnati Children's, our Cincinnati Children's Health Equity Network and our Asthma Learning Health System, as examples of the ways in which we can really formalize improvement science with an equity lens. So the Health Equity Network, otherwise known as HEN, had the shared purpose of reducing inequities in child health outcomes. Our population of interest was Cincinnati youth, and hospitalizations was our outcome that we were trying to improve. Our denominator included all youth within an 8 Southwest Ohio County region. And then our numerator were, of those youth in the area, how many were hospitalized. We segmented our data by race, payer, and neighborhood. We developed key drivers with our partners. Our scalable unit were the clinical areas, whether that be ambulatory clinics or inpatient units, as well as neighborhoods. And we formalized testing by building this learning network structure. And so what you're looking at here is the total number of admissions per 100,000 children, 0 to 20 years of age, in the 8 counties in Southwest Ohio. And you can see there's variation in the hospitalization rates over time. We segmented this data, and what we found was that our Black patients, which is indicated by the orange line, had a higher rate of hospitalization than their counterparts. And you can see that equity gap is quite remarkable. We further segmented this data to understand what this gap looked like when we just looked at physical health reasons for admission, and mental health reasons for admission. And as you can see, the gap between Black patients and all other patients persisted. So this served as the foundation for the launch of our Health Equity Network, where we recruited teams from across the hospital to do equity-oriented quality improvement with our shared global aim of excellent and equitable health outcomes and our smart aim of decreasing the gap in hospitalization rates between Black patients and all other patients by 10%. We had several key process indicators as well. And then the really important thing and the power of this work is that even though we had teams that were coming from across the institution, from different clinical areas, that were working on different conditions, the drivers of equity gaps are likely all the same. And so we drafted this key driver diagram, and I'll walk you through our primary drivers. We thought that in order to achieve this goal, we needed to think about access. Essentially, how we ensure that every child has access to the right care at the right time, in the right place, and in the right way. We need to think about meeting needs. So how do we address social and structural determinants of health? We needed to think about building connections. So how do we fortify effective and seamless links across healthcare systems and between health and community systems? We needed to build trusted relationships such that partners are welcome, heard, and a part of the work. And finally, we needed to build a system where we could learn by doing. So fortifying a learning network that aligned with both institutional and community priorities and was bolstered by a culture of equity. And so we started off small. We initially had 4 teams in our Health Equity Network, and we eventually grew it to 10, and now it's actually 17 teams. We had a core team which highlighted the operation leads of the work, which included Dr. Andy Beck and myself, as well as leads from a quality improvement, data analytic, community engagement, and project management perspective. And we also outfitted each team with that same level of support. Team leads had funding to support their time in the network, and each team had access to QI, data, project management, and community engagement support. In order to foster an all teach, all learn model, we met twice a month as a network. We met to have a monthly action period call where teams would share what they were testing, their successes, their barriers, their lessons learned, as well as their plan for testing for the next 30 days. We also had monthly solutions labs where we would bring in subject matter experts who would focus on the key drivers that I just reviewed and think about the interventions that we could test as a learning network together. So here are some of the successes from the Health Equity Network. We had an asthma team that was focused on improving outcomes for a population of children that had moderate to severe asthma, who were seen in our primary care clinic and also sought care in our asthma clinic that was staffed by our pulmonary and allergy subspecialists. And you can see here that the rate of asthma-related admissions between Black patients and all other patients, we see that narrowed equity gap over time, which is really impressive. And the improvements that we think drove these outcomes are likely due to the embedded social needs and response screening that occurred within the clinic and connecting families to resources that could help them mitigate things that were impacting their health, whether that was legal aid advocacy, public health services, connecting them to community health workers embedded in the asthma clinic or the primary care clinic, and we saw significant improvement. We had an adolescent medicine team that was focused on reducing hospitalizations for their patient population with a specific focus on those being admitted for various mental health crises. The adolescent medicine team staffs a teen health center that sees a predominantly Black or African American and publicly insured patient population. And they were able to see a notable decrease in their mental health related admissions by doing several things. They embedded a trauma-informed integrated behavioral health model into their clinic. They started changing their processes as it relates to how they followed up with patients. They wanted to mitigate barriers to medication adherence, which often included transportation barriers or education about their meds. and they connected high-risk patients to social workers and community or care managers who could follow them longitudinally. Some other improvements to celebrate: we have a type 1 diabetes team within the Health Equity Network that wanted to decrease hospitalization rates for their Black patients with type 1 diabetes. And as they looked at their data, they noticed that there was a gap in terms of equitable deployment of technology, of type 1 diabetes technology dependent tools like CGM, so continuous glucose monitors, and insulin pumps. So they focused a lot of their work on making sure that they narrowed that gap in access to those tools for their Black and publicly insured patients. We had a peri-op team within the Health Equity Network that wanted to decrease preventable cancellations of procedures, and they focused on doing social needs screening and response, and they noticed a lot of their patients who were canceling had transportation barriers, and so they put things in place to address those early, and they have started to see a decrease in cancellation rates, and now they're focusing on patients who speak a primary language other than English. And this is our sickle cell disease team that wanted to decrease the rate of missed appointments for their patient population. They also embedded social needs screening into their clinic. And then they also partnered with our Medicaid Pediatric ACO to ensure that families had access to community health workers who could help them navigate other challenges they were experiencing. And so this is just to show the ways in which we have slowly started to narrow the gap in our total admission rate between our Black patients and all other patients. And the goal is to continue to grow the network and add more teams that are focused on various subpopulations within Cincinnati Children's to further narrow and eliminate that gap. Now I'll talk about the Asthma Learning Health System with the shared purpose of reducing inequities in asthma outcomes, specifically asthma-related hospitalizations. And so we know that asthma care, delivery, and outcomes are complex, costly, and inequitable. And asthma in particular is pretty unique. Unlike other chronic pediatric diseases like type 1 diabetes, where we know that a patient is going to be connected with a subspecialist, asthma management can vary and can be fragmented. It's difficult to determine a patient's asthma home. Likewise, we know that silos within healthcare systems exacerbate the fragmented care that these kids are receiving. We also know that inequities abound as it relates to asthma. So the national hospitalization rate for asthma is about 88 per 100,000 youth across the United States. And what I'm showing here on this table is the far higher asthma-related admission rate that exists within Cincinnati. So within Hamilton County, you can see the rate is 263 per 100,000. The neighborhood of Avondale, which is predominantly Black and is where Cincinnati Children's sits, has an admission rate of 559 per 100,000. The 10 disadvantaged neighborhoods in Cincinnati have an admission rate of 496 over 100,000, and you can see the admission rate for Black children in Cincinnati is nearly 600 per 100,000. So we asked ourselves, what would it take for us to achieve a reduction in the Hamilton County admission rate such that it was 10% better than the national average? So we did some calculations, and you can see the number of admissions we would have to eliminate over time each year in order to achieve that goal. So we launched an asthma learning health system after a year of doing a lot of design sessions and qualitative work. And you can see here our goal was really to reduce the number of asthma-related admissions for one neighborhood, which was Avondale, and to build towards decreasing asthma hospitalizations across all of Hamilton County. Our primary drivers were excellent and equitable evidence-based acute asthma outcomes, excellent and equitable evidence-based preventive asthma care, health promoting homes and neighborhoods, coordinated accountability and action within the healthcare system, and effective and seamless connections between healthcare and community partners and households. We also thought about what are the intervention categories that we really wanted to prioritize. And we thought access to medications, reduction in exposures and triggers, and building connections were the 3 categories that we wanted to prioritize. And so here are some of the example interventions that fall within each of these categories. Access to meds, runs the gamut of ensuring that we're prescribing evidence-based medications, that kids have meds in their hand prior to discharge, that we are thinking about ways in which we deliver meds to school or ways in which kids could reliably get their medications administered to them at school. Thinking about reductions in exposures, again, families who are living in dilapidated housing, how could we connect them to legal aid or to the health department to mitigate those risks? And connections was really thinking about how do we identify high-risk patients that would benefit from community health worker or care management support. And so different from the Health Equity Network, we actually had teams that were both internal to Cincinnati Children's and external to Cincinnati Children's. This included nurses from some of the school-based health centers from Cincinnati Public Schools. The health department is a part of our asthma learning health system and other key partners. And then we knew that data would be pivotal in terms of doing this work. So we spent a lot of time building dashboards that we could use to inform our interventions. So this is a screenshot just showing patient admissions by neighborhood. And you can see the different ways in which you could filter this information. And then at the bottom, you were able to get patient level information that then could inform your actions. This is a screenshot of a tool that we put together, a patient prioritization tool. We wanted to be able to readily identify patients that had several high-risk factors such that we could target them early and figure out how to support them. So patients who had ICU stays, admissions, steroids, ED, and urgent care visits, and we would be able to filter this by neighborhood, by race and ethnicity, insurance status, and use that, again, to do targeted outreach to these patients to determine how we could best support them. And then one of the things that we implemented was a weekly asthma action huddle with the goal of promoting situational awareness and driving towards action to improve asthma outcomes. So this was a weekly call with a multidisciplinary team that included physicians, nurses, asthma coordinators, community health workers, social workers, QI, and data analytics support. And we would review patients that we would find on our dashboard or patients who were admitted to the hospital over the course of the week and develop actions that we needed to take in order to support those patients. So we leveraged the huddle to learn about what is required to coordinate interventions at scale. And so finally, I think what we are trying to articulate is that we need a roadmap towards action. And in order to do this, we have to build the evidence base. We have to figure out the ways in which we unleash motivation, insight, and expertise of partners and leverage co-production with patients and families. We have to think about establishing common objectives to build will and have shared purpose. We need to think about the power of data and integrate data streams. We need inclusive coalition building for rapid learning and action. And we need rapid iterative prototyping to adapt and scale interventions that work. And we can't do any of this without amplifying the lived experiences of our patients, families, and community. So I'll end with this quote, which I love, because I think it very much speaks to what we are trying to accomplish. The inequities in healthcare that existed at the turn of this century have persisted or worsened. We know why. Decisions made about what to improve and how to improve without first asking crucial questions such as who benefits or who gets left behind only preserve and cement inequities. Designing quality initiatives for certain populations rather than with the people most affected will lead to less improvement, less sustainability, less trust, and less equity. So thank you all for taking the time to listen, and I'm happy to answer any questions.